خيرا. رب اشرح لي صدري ويسر لي أمري واحلل عقدة min lisani yafqahu qawli. Ya Allah, ya Rahman, ya Rahim, sesungguhnya kami berhimpun pada hari ini bagi menyatakan kesyukuran di atas kurnia-Mu yang tidak ternilai. Jadikanlah kami hamba-hamba-Mu yang sentiasa bersyukur sama ada nikmatnya sedikit maupun yang melimpah ruah kepada kami. Ya Allah, ya Hayyu ya Hayyu ya Qayyum, sesungguhnya Engkau Maha mengetahui bahawa kami di sini ingin menimba ilmu-Mu yang sangat luas bagi mengembangkan potensi kami sebagai hamba-Mu yang Engkau redai. Istiru berkati dan rahmatilah perhimpunan kami ini. Kurniakanlah kepada kami ilmu-Mu, sinarilah hati kami dengan cahaya dan hidayah-Mu. Semoga dengannya kami mudah menerima dan menghayati serta mengamalkannya. Ya Allah, ya Rahman, ya Rahim, kurnialah kepada kami kesihatan anggota, kecerdasan minda, ketenangan jiwa, kekuatan semangat. Semoga dengannya kami mampu menepani cabaran, berdaya saing dan mampu mengangkat martabat diri keluarga, masyarakat dan negara. Rabbana atina fid dunya hasanah wa fil akhirati hasanah wa qina adzabannar. Walhamdulillah rabbil alamin.
Okay, thank you Dr. Fadli for the prayer. We now request our Honorable Head of Department, Associate Prof. Dr. Rosna Baha to address the gathering and give her welcoming speech.
Okay, dengar suara Halo Zam? Clear my suara I clear Dengar ke? Assalamualaikum, dengar ke suara saya? Okay, thank you. Bismillahirrahmanirrahim. Assalamualaikum and a very good morning to everyone. Thank you for being with us today in the webinar, the Advanced in Trephine Hematology Workshop 2. I sincerely thanks and acknowledge every one of you who extended help to us for making this event a grand success, especially to Dr. Trephine, our chairperson for the event today, and Dr. Razan, our moderator. Thank you so much. On behalf of my team, we would like to thank to the one and the only speaker, Dr. Ahmad Toha Samsudin, a very experienced man, so committed and never say no. Every time we ask him for help. Thank you so much, Dr. Ahmad Toha. And to all my students, especially, I would like to point your attention to the list of exciting topics that will be discussed the whole day today. Okay, and in the coming next few hours, we will learn and add on knowledge on trephine morphology related to hematolymphoid disorders and technical approach on common problem related to trephine biopsy interpretation. While the next series will be the next week, right? Will be enhanced MPES student and of course all of us actually hematologists on hands-on experience and professional skill in discussion few diagnostic dilemma cases. So lastly, without taking any more of your time, I would like to warmly welcome everyone to our webinar. And I request everyone, especially MPES final year student, exam goers, okay, to make use these 3 days efficiently. Okay. Assalamualaikum. Thank you.
For Rosna for the opening remarks. Now we are all geared up for our seminar today, and we are overjoyed to have you here virtually as our speaker today. So without further ado, let us now welcome the man who doesn't need any introductions and known among all of us for his wisdom and knowledge in extensive experience in diagnostic service, hematopathology, and also lymphoreticular pathology, our honorable speaker, Dr. Ahmad Toha.
Hello, Assalamualaikum. Hello, can you hear me?
Yes, Dr.
Okay. Thank you, Prof. Rosna, and good morning. Assalamualaikum to everyone. Dr. Razan. Okay, shall I proceed with the first presentation today? Step by step in bone marrow examination. I twisted a bit the topic from the earlier proposed topic given by Dr. Razan. By slight modification into the topic into step by step in bone marrow examination. I got this feedback from when I asked your seniors in Queen. There are a few of them. So when I asked them how should I approach on my presentation for this coming bone marrow pathology workshops. So they said, okay, first thing, try to share with them on the approach into reporting bone marrow to refine. So, okay, I will start with this step by steps in bone marrow examination first. Yeah, thank you. Okay, we must remember that the normal bone marrow, okay, it is not a random mixture of various blood forming cells. We must remember that when you look under microscopy, the bone marrow, of course, for the beginners, you might notice that there are so many blood forming cells. There are erythroid, there are myeloid, megakaryocytes, and also lymphoid cells, and a few other cells. But then, if you notice as we go further, you will find that this particular hematopoietic cells, they are not just randomly distributed within the marrow spaces, but they have very structured topography, what we call topography, which we need to appreciate because the changes in that topography will indicate certain pathology, or the changes in the population, the percentage, the ratio will also indicate some pathological changes. So actually in the marrow, this marrow is a highly organized and very specialized tissue in terms of topography, distribution of the cells, as well as the presence of accompanying cells. Yeah? So the other cells that always there in terms of ratio. Say for example, in the lymph nodes, you might find the the B cells, the B lymphocyte more than the T lymphocyte, but it's opposite in the marrow where you get T cells more than B cells. So before we proceed with the reporting the Trephine biopsy, we must first familiar with the normal bone marrow and also the changes throughout the life, because the age will also influence the cellularity of marrow. Okay, this is the main component of bone marrow. The bone, which comprises cortex and also trabeculae. The cortex is okay. Superficial to cortex is you have cartilage. Okay, we start with skin first. Skin, and then you have subcutaneous adipose tissue, and then you have fibrous tissue, then followed by cartilage and cortex. And then you get the trabeculae, bone trabeculae. Then you have a stroma here. The stroma comprises blood vessel, fibroblast, reticulin, adipose tissue in between the bone trabeculae, intertrabecular spaces, and also some iron and also matrix. And then the cells here, we have two components, hemopoietic cell as well as non-hemopoietic cells. This is, we will elaborate further on this one. Okay, the bone, they have a periosteum, cartilage. You can this cartilage, especially in pediatric and elderly biopsy, and then followed by cortical and also trabeculae bone. Yeah, this is the arrangement from the most superficial into the trabeculae. So periosteum, cartilage, cortical bone, and also trabeculae bone. The fat spaces, the fat spaces, very adjacent to the bone trabeculae, we call it the first fat space. This is very important because in differentiating between MPN, myeloproliferative neoplasms, and MDS, because both presented with hypercellular marrow, in MPN, the first fat spaces will will be obliterated as compared to MDS. In MPN, they will be obliterated together with hypercellular marrow. Unlike in MDS, where they preserve the first fat space. Okay, the cortical and subcortical marrow. This is the cortex, where you get quite thick layer of cortical bone and very minimal marrow spaces. And the cortex, this is the cortex, and then you get this marrow, first subcortical marrow spaces, and followed by the normal marrow spaces. The normal bone marrow defined on cellular component. Yeah? So we have here myeloid component, erythroid component, megakaryocyte. Okay, these are the three common cellular hemopoietic component of Trephine, of marrow. The myeloid in the normal adult, the ratio between the ME ratio, the myeloid and erythroid, they are small myeloid as compared to erythroid, with the ratio of 3 to 4 to 1. And megakaryocyte, you have between 2 to 4 to in high power field, or you can get the range of 5 to 6 in one marrow spaces. And lymphoid cell, which is a lymphoid cell, comprises of BNT. They are a range of 10 to 12% only. And this lymphoid cell, normally in the normal marrow, they are distributed very individually, rarely forming aggregates or what more nodule. Basophil and eosinophil. Basophil is barely detected by H&E because through processing, the basophilic granules dissolve on processing. What we have is only eosinophil. Then you have monocyte and also dendritic cell. This monocyte and dendritic cells, because we combine both monocyte and dendritic cells, because it's when you subjected to special stain on immunohistochemistry set, for example, CD68 or CD163 or CD14, you will tend to get both dendritic cell and monocyte picking up those stains. So you have to differentiate morphologically. Monocyte tend to be very round, mononuclear cell, just like lymphoid cells. Dendritic cell, as the name given, they are very dendritic, very branchy looking cell, picking up those things. So when you are looking for CMML, for example, or AMOL with CD163 positive, then your quantification should disregard those cells with all the dendritic processes. And then you have very few plasmacytoid cell. This is very important that this plasmacytoid cell, very few. But I mean very few, this is very occasional. So when you have clusters of this plasmacytoid cell, then it is definitely a pathology. And plasma cell, you have only about 2%. 2%. They are not normally confined within the perivascular spaces. Later, when during the workshop, I will show you on the pattern on the slides before we discussing cases. And then you have few muscle. This muscle we can detect it by morphology. We can identify small with centrally located nuclei, but there are very few. And then of course you have blast. Blast is very individual. Not remember, blast is not forming aggregates or clusters, because when you get, say, for example, CD34 positive blast, held in clusters of 3 cells, but they are in clusters. So be careful whether we are dealing with something of early malignancy, early relapse, or residual disease. And then, of course, then the next will be hematogons. We will elaborate further on this one. Okay, in terms of topography, this is very important, or organization of the cells. That's why we mentioned earlier that the marrow is very specialized, organized structures. Despite you have number of too many of small round cell, but they are actually of different topography. This is the this is the okay, sorry. This is a trabeculae, bone trabeculae, and the immature myeloid will reside along the paratrabeculae, and then as these myeloid cells, precursors, undergo maturation, so it will move to the the central part of intertrabecular spaces. So the maturing myeloid will move from here to here. When I meant by immature myeloid, it does not mean that you can pick up CD34 blast cell here. No, because the moment the myeloid cell undergo, or any cells, a lymphoid cell, undergo maturation, showing differentiation, for example, then you won't be able to detect any blast cell. So the immature myeloid will reside along paratrabeculae. This is essential later because in hypercellular marrow due to MPN through MDS, first you must check your MPO whether the topography of immature myeloid cell intact or actually they are already all moved towards the center. And then the maturation, they move toward the center. The erythroid will be within the intertrabecular spaces. And the difference between erythroid, the location, they are away from paratrabeculae, but they are always held in the colony. So when you are describing the erythroid, the keyword for erythroid is a colony. The colony pattern, they are always in colony. So you have groups of erythroid with different stages of maturation. And megakaryocyte will also be at the intertrabecular surfaces to the center, but they are of course morphologically different. You can recognize because they are big, they are large, and they are multinucleated, unlike immature, unlike myeloid. So this is the erythroid. This is what I mean by forming colony. They are groups of cell. This is a group of cell, and they are of different maturation. You get you can get pronomoblast, normoblast, and then chromatic normoblast become retic. So this is all in maturation. Later, when we are talking about MDS, for example, you will notice that the most immature form of erythroid, they are separated from the more differentiated one, and then they lost the colony pattern. Okay, this is the erythroid in colony with various stages of maturation. It's quite easy. Later, when you are dealing with the pediatric Trephine, for example, patient 2 or 3 year old ALL, post chemo, day 15, for example, you will get such abundant, such a florid reactive erythropoiesis, and you will observe so numerous of immature cells, but they are all always located very near to the matured nucleated RBC, so these erythroid precursors. So we know that those immature, the blast-looking cell with vesicular nuclei actually belongs to erythroid colonies. The normal ME ratio, okay, in adult is a more myeloid as compared to erythroid. So they are between 3 to 4 to 1 as compared to neonate, the pediatric, where you get more erythroid as compared to myeloid. Eosinophil and basophil. Okay, you can get eosinophil by eosinophilic state granules. You can recognize under H&E. Okay, as I mentioned, basophil precursor and the mature form is very difficult to identify as one thing. They are smaller in number, and then the granule soluble in water and also difficult to stain. That's the problem with basophil. So we have to rely on peripheral count, on peripheral blood when you are interpreting CML or in CMML in accelerated, for example, then or in blast transformation, you have to get to know the peripheral basophilic count. Okay, megakaryocyte located in the central region, and also parasinusoid, parasinusoid, because the are lobated nucleus, lobes joined by very, very thin strand of chromatin, and the cytoplasm phrase at the edge as platelet are released. So this is the megakaryocyte. So they are releasing the platelet into the sinuses. Okay. And sometimes you may get naked nuclei devoid of cytoplasm, often found around the sinusoid, because they already release the cytoplasm, the platelet into the cytoplasm, into the circulation. Okay, this is the megakaryocyte. So megakaryocyte, because being, if you take, say for example, you get, this is the megakaryocyte, and the normal megakaryocyte will have abundant cytoplasm. That's the key into recognizing the megakaryocytes, normal megakaryocytes. Okay, so but in practice, you may find various morphology of this megakaryocyte, simply because the way of the megakaryocyte has been transacted. If you take this megakaryocyte, okay, you cut along this way. Sorry. If you cut across this megakaryocyte through this plane, then you will get almost two separated nuclei like this, for example. Then if you take this one, the plane is across like this, then you may get only one nuclei. So that's why in megakaryocyte you get various morphology in describing their presence. But the most important thing, they are large, always large, and they have abundant cytoplasms. Okay. So the moment later, by recognizing this normal megakaryocyte, Later, when you are dealing with MPN, for example, ET, for example, or MF, or in MDS, for example, then you get the all typical megakaryocytes. As I mentioned earlier, you may get naked nuclei very adjacent to the sinuses as they release all the platelet into the sinuses. And the immunochemistry markers commonly used in Malaysia, we are using CD61 for the megakaryocyte. So when looking at CD61, remember this CD61 stay in the cytoplasm. Okay. So when you are you will get two pattern of CD61. One, this stand entirely. You get a block positivity without having nuclei. So always look those with nuclei because they will have the nuclei at the center and doesn't pick up the stain. You have sort of some like empty, unstained indicate the nuclei of megakaryocyte. Okay, and some megakaryocyte will have emperipolysis, meaning they are phagocytose, the leukocyte, neutrophil lymphocyte, or sometimes RBC as well. So we call emperipolysis. This is CD61 highlighted better. And please not to be mistaken with macrophages. And then this is monocyte. Okay, I remember I told you you have monocyte and also dendritic macrophages. Dendritic macrophages is commonly seen as the part of the stromal component, but the monocyte, okay, you can differentiate the two because the monocyte tend to be mononuclear cells with cytoplasm, and the dendritic macrophages will also pick up this marker CD68, but they have sort of tentacles at the edges. So normally when you are estimating post treatment for AML, myelomonocytic, for example, or AMOL, for example, or they are transforming CMML transformed into AMOL, for example, then look carefully for this particular population, and just ignore this dendritic macrophages. The marker we use, commonly used for monocyte and for this monocytic series are CD68, CD14, and CD163. You can also use CD11C as well. And then you have plasmacytoid dendritic cell picking up CD123. Always individual cells, there are very few. More, you can recognize the morphology because they are the nuclei are rather oval shape. It's not really showing the plasmacytoid where the cells are having eccentric nuclei as in plasma cell, but they are rather oval shape nuclei. And this is the plasma cell. Okay, plasma cells, most of the time they are single. If they are in groups, you will notice they are in one cell thick groups surrounding capillaries or surrounding blood vessels. You can only allow one or two cell thick of this plasma cell around the perivascular. In other areas, they are distributed singly. Okay, This is the stain. This is germ cell stain, highlighted rather in groups of perivascular, around the capillaries. The normal marrow will have more kappa than lambda. This is the double stain, highlighting the kappa is the brown and the lambda is the one stained red. So you have here 1, 2, 3, 4, 5, 6, 7 kappa to 1, 2, and 3 lambda. So the upper lip clonal with kappa predominant as compared to lambda. So when can you consider the plasma cell become pathological? One thing, when the number increase, there are more in aggregates, and they are either the ratio of kappa to lambda reverse. I mean, in this case, lambda become predominant, or overpopulation of kappa exceeding the normal ratio. The lymphocyte, okay. Okay, the lymphocyte, we have, okay, in children, 30 to 60% of cells, of nucleated cells in the marrow are composed of lymphocytes. But in adult, there are far less. And most of the time, they are scattered, distributed individually, not forming aggregates or clusters. In the marrow, adult marrow, CD8, the T cells will be more as compared to CD4. So that's the normal marrow. So when you are suspecting, say for example, hepatosplenic T cell lymphoma, for example. So first you must check, because in hepatosplenic T cell lymphoma, for example, the T cell can be very subtle, the population, but the pattern, the intrasinusoidal pattern giving you the clue. So, and they have the combination of CD4 dominant as compared to CD8. And so when they have the reverse 4 more than CD8, then think of pathology. The normal CD4 to CD8 ratio is 1 to 4, roughly about 1 to 4. That means 4 CD8, only 1 CD4. So that the normal ratio in Trephine of adult, as compared to peripheral nodes, more CD4 as compared to CD8. Mast cell very few, and then as I mentioned to you, they are quite easily recognized because they are small and sometimes centrally located, and they have this granular nucleus. Sorry. Okay. So there are not many, but you can use CD117 or mast cell tryptase for these mast cells. Okay. Remember, this is 117 because 117 can be also stain the plasma cell and also stain the immature or blast or myeloblast. So later, when you are talking about MPN, AML, for example, or residual post chemo of AML. So be careful in interpreting CD117. Okay, for the blast cells, they have only 1 to 3% of all marrow cells. They have granular cytoplasmic staining in an annular fashion around the nucleus. This is granular staining. They are not diffuse cytoplasmic staining, but the staining showing the granular appearance of CD34. So, non-paratrabecular interstitial location. Yeah? Remember I told you because the paratrabecular is the site for the immature myeloid, and then as they go mature, undergo maturation, they will move towards the intertrabecular spaces. But for the CD34 positive blood cells, they are located non-paratrabecular interstitial location. Yeah? And hematogones. Hematogones, okay, this is, hematogones is the bone marrow B cell precursor. How to recognize, how to differentiate this hematocone from residual blast cell in ball or tall? Okay. Hematogones, if you look carefully say, if you put under 40, for example, you will notice those blast cells, the blast-looking cell, they have size and morphology. Actually, they bridge between the mature and the plastic lymphoblast. You have here, the larger cell is very blast-like cells. And also you have on the similar field, you get the more maturing, more differentiated cells. So you have stages of maturation. Okay. When can you get this, the hematogones? In regenerating marrow, post-chemo, in patient with autoimmune or congenital cytopenia, patient lymphoma or patient in neuroblastoma or even patient with HIV. Okay. Especially in children and also, adult on treatment. No? Okay, for the hematogones, how many? How many? What you can get actually very florid this lymphoblast-like cell, and yet we consider as hematogones because the reactive, the hematogones, the body producing hematogones is different from one patient to another patient. Yeah. Sometimes you may mistaken as residual leukemic cells, or you might call it as not in remission, but there are actually hematogones. So there are ways to recognize, to differentiate these hematogones from residual blast. Huh? Okay, now we move to indication for bone marrow examination. We have discussed all the cell population in normal marrow. Now we discuss on the indication for bone marrow examination. Indication, workup for abnormal clinical and also lab finding. So any lab finding can be cytopenia or cytosis or unexplained organomegaly. Organomegaly here in our context is a reticuloendothelial system, such lymph nodes and any lymphadenopathy or hepatosplenomegaly. So that kind of situation, or without organomegaly, but a patient comes with cytopenia, unexplained cytopenia or cytosis. So this is one of the indication. The other indication for the marrow will be for the diagnosis and monitoring of malignancy. So either from marrow-based disease such as acute leukemia, MPN, or systemic hematological disease malignancy such as Hodgkin lymphoma. Yeah? And also for the staging of malignancy, lymphoma, either on initial diagnosis or as follow-up. Some cases of non-hemopoietic malignancy, such prostate or CA breast, especially when it comes with cytopenia. And workup for some non-neoplastic disorder, aplastic anemia, PNH, HLH and storage disease, and also for follow-up, we consider as a follow-up mirror. To see on the treatment response or post-transplant or low-grade lesion transforming into high-grade lesion, and dry tap due to fibrosis. Okay? Dry tap due to fibrosis, I have been discussing with our colleagues, the hemato colleagues here in Queen, and we noticed that as low as grade 1 grade 1, yeah, using the TL classification, you have grade 0, 1, 2, 3, over 3. Yeah? So grade 3 would be osteosclerosis, dense fibrosis, collagen band. That's it. So as low as grade 1, myelofibrosis, then you will get dry tap. Not to wait until grade 2 or grade 3. Even as low as grade 1, you will get a dry tap. Then in that case, or you get a discrepancy between the finding of your aspirate and also the marrow. We have one case recently where the aspirate was reported, aspirate and also flow reported as M6. But on Trephine, we changed the diagnosis of M7 simply because M7 was not aspirated during the procedure because of the fibrosis. And M6, the so-called M6 actually are non-neoplastic cell. So we skip this technical. Okay. The systematic approach on bone marrow reporting. Yeah. Okay. This is an advice from my former supervisor in Oxford. Prof. Kevin Gutter, he mentioned that it is important to have an organized approach to the examination of bone marrow section in order not to miss diagnostic features. Okay. I noticed our reporting doesn't differ very much as compared to when you are reporting a spirit. I noticed your spirit will also mention about systematically on erythroid, granulocytic cells, series, megakaryocyte, and then describing the morphology, if there is any dyshemopoietic or others. So sort of the kind of arrangement. To us in histopathology, this reporting Trephine also quite similar to other systems. For example, in this reporting renal pathology or liver pathology, they have very systematic approach because and in histopathology we have now in avoid to miss few essential point. So we come up with what we call as a proforma, especially when describing the malignancy. By using proforma, you most of the time you won't miss the essential features. First, okay, assess the architecture of bone marrow Trephine. Yeah? This is something which is not available on aspirate. Yeah? So assessing the architecture, we have to look under ×4 and or ×10 lens. Yeah? And here we are assessing the adequacy, meaning adequate 10 marrow spaces or 7 cellular marrow spaces, And then there's adequacy. Yeah? And also cellularity. You can assess cellularity whether is it hypercellular or normocellular. But we must remember the marrow is unlike blood. Because blood, if you take blood from your right side, as compared to the your left side, it almost similar. Meaning, if your right side is giving you microcytic hypochromic anemia, for example, the blood from your left side will give similar features, but not so much for the marrow. Yeah? If you ever notice in pediatric marrow, for example, because pediatrician clinician loves to have a PET biopsy, Trephine on pediatric, and unlike adult. And you notice the pathology also quite focal, despite acute leukemia, for example, acute leukemia, but one side become very hypercellular, the other side is become or normocellular or hypocellular. Or sometimes you get a post chemo, the marrow looks hypocellular, but peripherally they are normal full blood count. So when we are dealing with hypocellularity, you have to add further description. Those cells in the interstitium, yeah, because you have high increase the fat spaces, but what happened to the in the area between the stroma between the fat spaces? Are they really normocellular or they are really packed with cells? So that's also important. And then what happened to the stroma? Is it fibrotic, edema, or hemorrhagic? And topography, the cell topography. This is what we are going to assess using 4 to 10 times 4 times 10 lenses. Of course, topography will be more accurate if you assess topography by using immunohistochemistry, especially MPO for paratrabecular myeloid cells. Yeah? And then from 10, you move to 20, to 40 for precise morphological abnormality. Okay, be careful on 40. By doing this on good thin section, you will be able to differentiate single pathology or dual pathology. There are a few occasions when, because when you look, you have the immunohistochemistry, you tend to sort of bias your assessment. Okay, the whole thing has been CD20 positive. Okay, this is a case of the LBCL. But when you look carefully on under times 40, for example, then suddenly you realize, well, this marrow actually showing two population. One is the LBCL-like changes. The other cell is quite small. And then add another immunohistochemistry, it confirmed that this is a composite lymphoma consisting Burkitt's-like lymphoma and also mantle cell lymphoma. So times 40 is essential for precise morphological abnormality. Yeah? And we shouldn't use times 100 in our hematology examination. Because that 100 is only for microbiology, in looking for the TB, for example. For histo and hemato, we stop at 40. Oh, now the newer microscope, they have times 60 or 63. So you can use that in exchange to the times 100. Especially when you want to study the nuclear picture of those atypical cells. Okay, we have mentioned the adequacy So this is what we call as adequate marrow, adequate sample, adequate sample, because if you have marrow spaces with cells, later you have to look under high power. This is rather inadequate because probably this is still part of subcortical marrow because the bone are too many bone and then very few marrow spaces. So here's already hypocellular, here a bit crushed. So when you are trying to exclude a primary disease or even secondary, so you might fail to arrive into definitive diagnosis if you have this kind of specimen. Yeah? Here, then you have more cells to study with. Okay. How adequate is the adequacy? There is no standard answer, but a good rule of thumb. The 5 intertrabecular spaces would be sufficient for hematological diagnosis. For the primary hematological diagnosis, especially acute look, for example. And we first exclude the first 3 subcortical marrow because in adult, the first 3 subcortical marrow often hypocellular. So the false negative. But if you have hypercellular or normocellular subcortical marrow, please be careful because that's already giving you a clue of the pathology. Because most of the time, the first subcortical marrow will be hypocellular. Yeah. So adequate. Sometimes we consider adequate despite less than 5 marrow spaces, even subcortical if cells of concern are present. Say suddenly you get those atypical Hodgkin cell in the first subcortical marrow spaces. Then, okay, we despite only one subcortical marrow, we can still report as, okay, presence of Hodgkin cell in this marrow. So if what if you have more than 10 marrow spaces, yet no pathological cells seen? So the final report would be worded as no malignancy seen in this entirely submitted specimen. Okay, meaning we have examined the entire marrow spaces, more than 10 marrow spaces, and yet we couldn't find any. So despite having uh, peripheral cytopenia, for example, and then cytopenia plus lymph node positive, and cytopenia, you would expect something happening to the marrow, but then after examining the 10 marrow spaces, you couldn't find, even with immunohistochemistry, then you concluded as no malignancy in this entirely submitted specimen. Probably, even through my experience, I have seen, I was assessing a patient with CA breast and then come with cytopenia. So actually the positive cells only seen on the 21st spaces. So luckily that we have long marrow, and then the first 20 from subcortical was look so normal, but on the 21st spaces, you get cluster of those secondary. Cellularity, okay, you have either hypocellular in case of possible diagnosis of plastic anemia or hairy cell leukemia or even hypoplastic MDS with AML. Normal cellular, when you get normal cellular, so you have to be careful because what constitute this normal cellularity, whether is the normal hemopoietic precursors are all there, or actually normal cellular, yet the normal hemopoietic precursor are reduced, and replaced by pathological cells. For example, myeloma or lymphoma. And in hypercellular, quite easy because hypercellular will always indicate pathological, but you have to describe pattern. And what happened to the first fat space? You have homogeneous population, then likely to be acute look or Hodgkin lymphoma. If they are heterogeneous, hypercellular heterogeneous, you can get in reactive MPN or metastatic disease. Yeah. Okay, the cellularity. This is for, especially for our master student. In general, use this rule of thumb. Cellularity is 100 minus by age. Yeah. That means if you are 30, for example, then you expect the cellularity will be around 60 to 70, and with 30 to 40% of fat spaces. Okay. Okay, and then the stroma, look at the stroma. This is rarely giving you, I mean, we rarely focus on this unless it is something, because it's more common amongst the non-hematological diseases. You have blood vessel, vasculitic or amyloid deposit or dilated sinuses. This is among the common changes in the marrow. Fibroblast and reticulin, you have fibrosis and all collagenization. And fat or adipose tissue, finding you get the Gaucher's disease, Gaucher's changes or pseudo-Gaucher's. First fat space, intact or absent. And then iron deposit or hemosiderin-laden macrophages. Matrix, you get gelatinous transformation, especially in post-chemo amyloid, when it associated with myeloma, or you can get granuloma with or without castration necrosis. And in bone, you get osteoporotic changes, osteosclerotic or patches. Yeah? This is the few that you may encounter in the stroma and bone. Okay, you are using TL classification or WHO, accepted by WHO for the grading of fibrosis. This is grade 0. Sorry. This is grade 0. Grade 1, you have loose network of reticulin with many intersection, especially perivascular. Grade 2, you have diffuse and dense reticulin with extensive intersection. Grade 2. And here in grade 2, you may get focal bundle of collagen or osteosclerotic. But focal, remember, focal. And in grade 3, you have a diffuse and dense increase in reticulin with extensive intersection with coarse bundle of collagen and often associated with a significant osteosclerotic sclerosis. Okay, topography. One, we must remember, are all cell type present? You have grants, airy, and also mega. Are all these component present? Number 2, okay. Are any particular cells present in the normal number, in abnormal number? Okay. Normal, I have mentioned earlier, the grand series will be along paratrabecular and also periarterial. Airy in intertrabecular spaces and mega in intertrabecular as well as perisinusoidal. Remember, where is the grand topography will be paratrabecular as well as periarterial. No? Then you get abnormal pattern. This is the topography and then abnormal pattern. So when you get paratrabecular erythroid and mega colonies, they are either in MDS or MPN, yeah? Or megakaryocyte clustering. And this one best seen using immunohistochemistry. Okay. So this slide highlighted the megakaryocyte. The mega clustering in megakaryocyte is pathological. It's always pathological. The rest are the normal topography I have mentioned earlier. And in addition to that, we have, I need to stress here that megakaryocyte clustering is always pathological. No? Okay. So in assessing, describing the hematopoietic cell morphology, one is first cellularity, is normal, reduce or increase, and then or selective. Selective means is the only one type of cells or precursors affected, or actually overall increase or overall reduce. When especially when you are describing say all cell precursors are present. You mean airy, mega, but then they are reduced. They all present and maturation but are reduced. So normally this is the situation when you get something from outside infiltrating the marrow. For example, lymphoma or leukemia, lymphoblastic leukemia. Yeah? Unlike, but when you have only certain part of this among the three is reduced or overpopulation, then that will be the features of MPN. And then you have atypia, abnormal megakaryocyte in MPN. In MDS, you have giant mega, micromega, or mega platelet within cytoplasm of mega, within cytoplasm of megakaryocytes. Yeah? You get mega platelets. So the kind of atypia. And then abnormal maturation arrest because of dry induced, or asynchronous maturation in MDS, abnormal maturation in megaloblastic anemia, or imbalanced maturation, either right shifted or left shifted. And we have lymphoid infiltrate. Okay, the lymphoid infiltrate, this is the cartoon. Take this one is the trabeculae, and this is the lymphoid cells. Huh? So you have normal, this is normal, meaning the lymphoid cells are scattered individually within the intertrabecular spaces. So you have, when you get paratrabeculae, so you have paratrabeculae deposits, you have a nodular, you have interstitial, interstitial means like this, but they are increased in number, or diffuse, it involves the entire spaces, or random, or any combination. This is the pattern of lymphoid infiltrate. And each pattern denotes some pathological preference. For example, paratrabeculae alone are commonly seen in follicular lymphoma. Later, when you have paratrabeculae plus intertrabeculae nodule, for example, then it can be seen in advanced stage of mantle cell lymphoma, LPL, or marginal zone lymphoma, but certainly not CLL. So when you have both paratrabecular and intertrabecular clusters, you can exclude CLL. And if you have paratrabecular alone, always consider follicular lymphoma. For the nodular, you have this Hodgkin lymphoma and small cell lymphoma. But must first exclude reactive lymphoid aggregates. Interstitial T-cell lymphoma, hairy cells, and also a normal T cells. You can get normal T cell with interstitial infiltrate. And diffuse hairy cell, you can get hairy cell leukemia, CLL, and diffuse large B-cell lymphoma. And random, you can get random means you can either individual cells or one or two cells clusters. Can sometimes very subtle infiltrate. You can get in high grade Hodgkin and also non-nodular sclerosing classical Hodgkin. Yeah? And any combination of those pattern you can get in LPL as well as MCL. And lastly, the intrasinusoidal. This is very, very important because in intrasinusoidal, it looks on H&E appears unremarkable. Suddenly, when you stain with BNT cell, then you get cell arranged in quartz pattern, very special quartz pattern. And actually, when you double stain those cells and also CD34, CD34, then you will notice that those quartz cells in quartz are actually within the vascular channel. This is the paratrabecular deposit. Okay. This is a paratrabecular deposit. Patient with mental cell lymphoma. But in other field, you will get the intertrabecular aggregate as well. This is nodular, very nodular. If you notice this nodule, doesn't look like a reactive nodule because reactive nodule, they have different features compared to neoplastic nodule. Intrasinusoidal, as I mentioned here, on cartoon it's quite easy to highlight, but then when you put into the real practice, actually very difficult. It's only immunostain will help you. Okay. This is intravascular or intrasinusoidal. This is when you stain, then you get start to realize the arrangement. And here you have marginal zone B-cell lymphoma. You have interstitial infiltrate here. You have paratrabecular nodule. And you have here, okay, so this nodule is a reactive nodule. Actually, you cannot differentiate much just by H&E, but when you have this pattern, then of course you have to go to immunohistochemistry to prove that this obviously this is neoplastic and this one actually turned out to be T cell dominant rather than B cell. This one is B cell, and but this is T cell dominant. So that's why we concluded as a reactive nodule. Interstitial, you have here very interstitial, but you notice if they are quite diffuse interstitial, then I mean the appearance become quite pale. The marrow spaces become cellular yet pale looking, and all you can see now is residual erythroid colonies only. The rest has been replaced by neoplastic cells. This is a diffuse. classical presentation for CLL, very diffuse. Okay, then other cells, if any. Oh, sorry, okay. So when you are reporting, this is guideline of LPD interpretation. Yeah, interstitial lymphocytosis, reactive versus neoplastic, is hard to differentiate. You have to use immuno. Perisinusoidal or intracellular are suspect. When you get this mixture, this is very subtle. So you have to suspect about this perisinusoidal or intrasinusoidal. Paratrabecular infiltrated are neoplastic unless proven otherwise. Random irregular patches are likely neoplastic. Then plasma cells should not aggregate apart from around perivascular space. This is all pathological. MAM1 can be useful for monitoring low level of myeloma. So infiltrate can appear paratrabecular if there is crush artifact, so be wary of this. So these are few some abnormality you can probably ignore, but you have to put into the reports, not into your interpretation. Yeah, a rare paratrabecular lymphoid aggregate follicular lymphoma style a scenario when other than lymphoma staging, meaning patient the marrow was done for CA breast or prostate CA, for example, for the staging. Suddenly you observe, you found this paratrabecular lymphoid. Just ignore that. Okay. Unless, but in your report, you have to mention presence of those, and then proceed with the immunohistochemistry. Then if immunohistochemistry does not really support of follicular lymphoma, then just ignore that. Another scenario is a single microgranuloma, slight excess of scattered properly granulated mast cells on the slide. Minimal megakaryocyte atypia, especially in elderly or patient with myeloma. Subtle megaloblastoid changes. Minor topographic abnormality. All this one, especially in elderly patient, you might get all these changes. Just ignore and don't think seriously of pathological. Okay. Okay. This is a kind of reports, the proposed report. First, this is for the final year empath. The report, okay, should be organizedly drafted. First, include summary, clinical summary, sudden onset of giddiness, PBF shows perceptible, for example. And then indication for BMT, diagnosis to rule out aplastic anemia. Microscopy, you have a piece of core tissue measuring blah, 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 30 mm long, entirely submitted in one block. Then microscopy. And this is your role. Adequacy is adequate. So, you have adequate, meaning what? How many? It's good to semi-quantify the number of mirror spaces. Okay, adequate. It consists of 20 cellular mirror spaces, or it consists of 15 cellular mirror spaces and another 5 of crush with crush or sometimes adequate with only despite one or two subcortical mirror spaces. And then you have to elaborate further your cellularity morphology to justify your statement of adequate here. And then cellularity, hypercellular marrow, or hypocellular marrow or normal cellular marrow. So again, you have to if you are then try to semi-quantify how many because cells and also how many percent of fat spaces. Okay. Later during the workshop, we will try to use this format. Reticulin, is there any fibrosis? Okay, this can be assessed by two ways. One, of course, you have to routinely do reticulin stain, or number two, by looking the cell morphology, meaning if the cells are showing what's that streaming pattern, then likely to have fibrosis. And then topography, is it any topographical dysplasia? For example, here you have this topographical dysplasia with busy marrow and lost polarity. You get a mixture of all. You lost airy colonies, the erythroid glands, and also very mixed up. So very busy looking marrow. So and loss of polarity. Polarity means the glands are normal in the paratrabeculae, but paratrabeculae has been replaced by erythroid cells mixture with megakaryocyte, for example. Then you have to describe, and also your description later. It must be complement with immunohistochemical finding. Okay, then after describing the hematopoiesis, then on lymphoid cells, is there whether the lymphoid cells are the primary pathology or actually they are just normal reactive changes? So here lymphoid will include plasma cell here. Okay, you have adequacy, cellularity, reticulin, topography, hematopoiesis, lymphoid cell, and others. Others, we reserve these others for, say, for example, you are describing under lymphoid presence of Hodgkin cell and also granuloma here. Or you have here myeloma here, and also others put here as the bone showing osteoporotic changes. This one, we reserve others for describing non-hematological changes, and finally interpretation and also comment. Yeah? So I think that's all. Thank you very much.
Thank you to Dr. Ahmad. And now I would like to open the floor for question and answer session. The audience may ask the question verbally, or you can post a question in the chat box. Should I have a question? In terms of naked megakaryocyte just now, naked megakaryocyte, how do we differentiate it with the micromega? Like sometimes they may have like similar size, especially in case of diagnostic case of MDS where we have diagnostic dilemma.
Okay, naked mega won't pick up CD61 because they lost the cytoplasm, isn't it? Micromega, they have intact cytoplasm, so it should be detected by immunohistochemistry. But then on HNE, you may be mistaken as one of the lymphoid cells or another mononuclear cell myeloid or what. Most of the time, you are mistaken as lymphoid cells. And then indirectly, you can identify those naked mega when they are located just adjacent to the sinuses. Now the problem is how to recognize pattern sinuses as compared to adipocytes. Yeah? Some of the sometimes our junior hematologists here in Queen ask me. So it's very difficult. The easiest is when you stand for CD34, for example, because MDS certainly you need 34 because you have to assess the blast population. So the CD34 will also stain the sinuses. So those cells, those are the atypical cells with the cytoplasm, naked nuclei, adjacent to the sinuses. So those are the naked megakaryocytes.
So, the next question is, in terms of adequacy, let's say in a case of narrow assessment post-treatment, how about if we only have 2 to 3 or 1 to 2 complete narrow spaces, can we do consider it as adequate?
Okay. If we if we uh, if we pass it as adequate, I mean you can put it adequate, but with caution because with the one clinician take it as well adequate, but you fail to arrive into definitive conclusion, for example. So you can say, okay, we have only adequacy wise limited. We have one cellular marrow spaces. How to put it? Uh, but we have cellular marrow spaces, but limited with only one. Okay. We have limited one cellular marrow spaces for assessment. So the rest may be crush or what. So you have so at least we know our assessment are based entirely on that one particular cellular space, and that particular spaces can be representative or maybe not. So if you are able to say, okay, there are some TDT positive cells in clusters indicating residual disease or incomplete remission, okay. But if we that clusters doesn't show any blood cells, we cannot happily say exclude remission, incomplete remission because of limited diagnostic tissue.
Okay, thank you, Doctor. Is there any more questions on the floor?
Okay. Huh? Hey, sorry.
From the chat box, here we can see a question from Dr. Siva. Good morning, Dr. Ahmad. In monocytic disease assessment, you mentioned on CD68, CD14, and 160. What is the role of lysozyme in the diagnosis and monitoring of this disorder?
Okay. Yeah, you can use Selasuzyme as well. Actually, I have another slide. Actually, this slide has been presented in a recent MSH. The basic immunohistochemistry in Trephine pathology, but then I didn't put fully these antibodies into this lecture. But I will complement all this lectures, this immuno in our workshop, later lah. CD68, lysozyme, CD14, and also CD163. One more is CD11C. We are trying to adding CD11C. Still hasn't arrived the markers. Initially, because we believe that CD163, according to articles, they represent better on blast component. C8 is very sensitive but less specific in indicating the blast component as compared to CD63. But then another articles, they sort of contradict. They said there's no specific, of course they supported by their studies, that CD163 are equally sensitive but less specific. And through our experience, also same thing. 163, sometimes they highlight initially we try to believe that the 163 is good marker for assessing the residual monocytic blast. But then later through our practice, then we realized that 163 not really. Meaning we have myelomonocytic leukemia on treatment, and then when we during follow up, peripheral count has normalized, but then actually, of course, post marrow you tend to get more number of monocytes reactive in the marrow, and that pick up as 163 equally. So it gives us headache to differentiate between the reactive and monocytic. But then, so now we found another article saying that interpreting monocytic markers must be with morphology. That means you have to really look at the morphology and then interpret the markers together with morphology. This coming May, we will be attending a meeting on monocytic neoplasm in the marrow as well as the soft tissue. Which we will have for 2 days in Edinburgh. So let's wait. Let's wait for the updates lah. Hopefully, there's something new that we can apply here in Malaysia.
Thank you, Dr. Another question from Dr. Rusmawati. Hope Dr. can share examples for stroma changes. Example like edema, necrosis, and also pleural atrophy.
Okay. I have the slide. Actually, I have problem tak ada assistant ni. Nak switch from one slide to another slide. So, well,
we can bring it on during our workshop.
boleh, certainly.
And then another question from Dr. Trephine is, how many cells in cluster can we consider it as abnormal?
Okay, clusters. I just take the word from Prof. Babarabain. Babarabain is actually to you is mother of hematology, I would say, for those in hematology. In fact, I've been sharing my former supervisor's remark on her, because whoever doing attachment to London under Babarabain, the students will be subjected for the Trephine on her own. The patients, the students Trephine. According to her, she's an excellent morphologist. 34 shouldn't be in clusters in the first place. Normal marrow, you shouldn't get 34 clusters. So the moment you have 34 clusters, disregard of the number, meaning you have the number of 50% of cells are blasts, 34 blasts, okay? And then you have clusters. Or you have only 5% of CD34 positive, but they have clusters. So to her, cluster indicate pathological. So cluster indicate either this is incomplete remission, one, or early relapse. So cluster means three cells, they forming clusters. That is clusters lah. Dia tak specify pun whether it is tight cluster ke loose cluster. They describe generally as cluster. That mean because in normal normal blast, which is a 1 or 1 to 3% in normal marrow, they are very far apart actually. You get one marrow here, one cell, you move to another marrow spaces, then you find another cell. That's the normal CD34 positive blast. So you have clusters. That means clusters means almost the way that the slide that is shared to us was, to me, I describe it's not really clusters, but aggregates. So the aggregates is already considered, because you are not supposed to have a groups, whether it's a tight cluster or aggregates of 34.
That one is for CD34. How about like for CD117? Is it considered the same?
Okay, CD117 a bit tricky because, as I mentioned, CD117 can be seen in blast. CD117 can be seen in plasma cell, and we know plasma cell perivascular aggregates of plasma cell may be mistaken as, if you take 117, then we might be mistaken as blast. CD117 can also be seen in regenerating erythroid. CD117 can also be seen in mast cells. Okay, the mast cells quite easy because they are small, but erythroid, they are definitely they are in clusters. So be careful when interpreting CD117. It's easier on CD34.
Right. Especially in those acute leukemia with CD34 negative, that we are very dependent on the CD117.
Okay, boleh. But then you have to exclude. You have to exclude what? You have to exclude plasma cell and erythroid, because once you patient on chemo, as the marrow regenerating, you will tend to get many erythroid colonies, isn't it? So that one can be 117 positive. The easiest way is doing CD117 and combine the staining with whatever the leukemic cells. Meaning, if you are thinking previously was AML, then MPO, but then MPO and 117 would be difficult because 117 are also cytoplasm, isn't it? Try to find combination of nuclear and cytoplasmic staining. One for blast in the marker, precursor marker, one for the lineage marker. Probably you can do that. Or 117 stain with P53. P53 because P53 stain the erythroid precursor, and then 117 stain the cytoplasm. So if 117 is outside the group of P53, then likely to be residual blast lah, rather than erythroid, regenerating erythroid. Or or if the background shows many plasma cell, then you can combine 117 and MUM1 for plasma cell, 117 for the blast cell. So if they stain both MUM1 and also 117, then we know those 117 belongs to plasma cell. If they doesn't pick up the plasma cell, then by exclusion, there has to be belongs to some non-plasma cells or non-erythroid cells lah. Can we start on double stain?
Without any delay, we will continue with our next lecture on the reactive bone marrow protein changes.
Okay.